event, as I was saying, is hosted by Propel Hub. The first question that is often asked, what does Propel Hub mean? Propel Hub stands for Productivity Outcomes of Workplace Practice, Engagement and Learning. It's a major UK research and innovation investment run through the University of Strathclyde with 8 UK universities, really focusing on how we can work with employers and employees and other stakeholders to drive job quality and productivity through progressive workplace practices. If you're interested in these kind of events and our work more generally, please visit us at propelhub.org. During June and July this year, the ESRC Propel Hub project is working with the Healthcare People Management Association to host a series of webinars on workplace relations and productivity outcomes in the health and care sectors. And again, if you visit our website, you'll find more information about the events that have taken place so far and the events that are coming up, including this Friday's event on inclusive leadership in the NHS. So please do join us at that. But turning to today's event, as I was saying, partnership working is fundamental to employment relationships in NHS Scotland and has a strong record in producing outcomes of benefit to the organisation, its employees and patients. So how does it work and what exactly are those impacts? That's the focus of our discussion today. I'm absolutely delighted to be joined in that discussion by Professor Patricia Findlay, who's the Director of the Scottish Centre for Employment Research at the University of Strathclyde, and is also co-chair of Scotland's Fair Work Convention. And Patricia has extensive experience in researching partnership and its outcomes in NHS Scotland. We're also absolutely delighted to be joined by Shirley Rogers. Shirley is Director of Organisational Readiness at the Scottish Government and Director of the Scottish Government Resilience Room. That's as serious as it sounds. Sounds like a very challenging and serious position in the current climate. Prior to that, Shirley was NHS Scotland's Chief People Officer. Prior to that, she was Director of HR at the Scottish Ambulance Service. So after many decades of service leading people management in the NHS in Scotland, Shirley has chosen to move on to be a leader in resilience in Scottish Government at what must be one of the most challenging times in the history of public governance in Scotland and elsewhere. Shirley, before we do anything else, I want to thank you for your incredible leadership and service, and to all of your colleagues in NHS Scotland and Scottish Government for everything that's been done in the past year. Trish is going to speak for a bit about her research in this area. Shirley's going to speak a bit about her experience in leading and collaborating on partnership working in NHS Scotland. There is a Q&A function if colleagues would like to ask questions or make comments, and we'll also have some time for discussion at the end of today's hour together. So with that, I'm going to first pass on to Tricia, and Tricia, the floor is yours.
Thank you, Colin, and good afternoon, everyone. I'm going to focus today on some key issues in trying to frame partnership and giving everyone enough details so that people unfamiliar with partnership in NHS Scotland get a sense of how it operates. But I want to try and get through the presentation quite quickly, because it would be great to hear from Shirley, and also to get a sense from the audience about some of the issues that are raised by partnership working in NHS Scotland. And in doing that, I will use some slides so that I can skip past them fairly quickly, and I'll also draw on a number of research projects which our team at the Scottish Centre for Employment Research have been involved on over the last decade or so, to illustrate some of the points where appropriate. So partnership in the NHS has now been operating for about 2 decades. Since its inception in 1999, it's had 2 significant reviews. The first by Nick Bacon and Peter Samuel in 2012 concluded, as what you'll see on the slide, that partnership in the NHS was probably the most ambitious and important contemporary innovation in British public sector industrial relations. So its first decade was assessed very positively. Our team at Strathclyde, myself, Dr. Robert Stewart and Colin, who is our chair today, evaluated partnership over 2018 to 19. And in the period since the previous review, that landscape of health and social care had changed rather significantly with the adoption of health and social care integration, the development of regional services as part of the NHS and Scotland's National Clinical Strategy. So that review was really to try and look at partnership as it matured in the light of new developments in the NHS and in social care. From the very outset, the discussion of partnership has not simply been about good industrial relations, although good industrial relations are very, very important. The discussion of partnership in NHS Scotland has been inextricably linked to the delivery originally of a world-class health service, much more recently to improve the quality of service and social care, and the delivery of those world-class services by developing and delivering and embedding really constructive and effective workplace relations. So partnership was, as it says in the Designed to Care document that preceded it, it was about using a modern workplace, a modern workforce to deliver a world-class health service. And therefore partnership has to be assessed in relation to how it also delivers on that. Partnership also delivers on the statutory obligation on health boards in Scotland to deliver effective staff governance alongside the requirements to deliver effective clinical governance and financial governance. And that statutory underpinning has been really important in embedding the notion that attending to staff governance through partnership and delivering that through partnership is as important as the clinical and financial governance of NHS Scotland. So that triumvirate of governance standards interact with each other to deliver what should be the best quality health services. I don't want to spend an awful lot of time on the mechanics of it, but to just give you some flavour of what partnership looks like in terms of processes. So partnership in Scotland has its main strategic body is the Scottish Partnership Forum. The forum has key strategic roles, which are to undertake strategic oversight of the service and workforce implications of policy decisions, to influence policy around policy thinking around national priorities in health, and to champion, oversee and develop partnership as part of the broader staff governance standards. The Scottish Workforce and Staff Governance Committee, SWAG, supports the development of workplace strategy and the development and delivery of employment policy and practice so that the NHS can operate as an exemplar employer. And SWAG is also responsible for monitoring that policy delivery and ensuring effective implementation and appropriate consistency across employers. So in our research, people talked about SWAG being the engine room that delivers employment policy and support. STAC, the Scottish Terms and Conditions Committee, is actually a negotiating body rather than a partnership body, but it does notionally report to the Partnership Forum, although it's not formally part of it, and it largely operates independently through bringing together employers and trade unions, and it has a clear and very well defined role and remit to negotiate over pay, terms and conditions. But that very much from the point of view of being imbued with the ethos of partnership working and partnership behaviours. It does more traditional industrial relations, but it does it within the spirit and the values of the broader partnership arrangements. And the area partnership forums are the local representations of partnership within health boards. So area partnership forums have both strategic responsibility at a health board level, and they have operational responsibility at a health board level, and they interact with the national level structures to produce a holistic and connected system of partnership. So having very briefly looked at those kind of key aims and processes, I suppose the big question that anybody wants to ask about partnership is, what does it produce? And when we undertook our research, we were really interested in doing that by thinking about three key themes. So how partnership impacted on voice, on equity, and on effectiveness. And that's very consistent with the wider literature on partnership, where partnership is about giving employees a voice, allowing them to share in the benefits of what that voice produces, and producing broader organisational outcomes that are largely positive. So let's do a very quick summary of what that delivers in the Scottish context. There is no doubt that partnership in the NHS Scotland gives clear, overt, explicit, formalised voice mechanisms at all levels of the organisation. So people in the NHS know that there are voice mechanisms that exist that have particular forums that they can access and that their representatives can access. Thinking about voice more broadly, there was some variation in what people thought about the balance of voice and partnership. So voice was often, when we discuss discussing voice in partnership, we're talking about, can employees get a voice in other contexts? Some people in our research thought that the staff side, the union side, were not influential and were not listened to. Other people argued that they were too influential and they were listened to too much, and that limited the scope that managers, for example, had in addressing change. But there is no doubt at all that the predominant view was that the staff voice was crucial, influential, and helped to improve the delivery of policy, its content, and its implementation. So while there were some variation in what people thought, generally that notion was that partnership had delivered voice in the way that it was designed to. Has it delivered any greater equity for staff in the NHS? Again, there's a very strong sense that it has done precisely that. That despite a very long period of austerity during the time of our research between the two reviews, partnership actually delivered strong material benefits and protections to staff. And that clearly has cost implications, but many of the partnership stakeholders were able to identify that there was a huge return on that. So it produced industrial harmony, more engaged staff, helped with recruitment and retention, and that those were all crucially important outcomes for employers in terms of feeding into continuous improvement and better patient outcomes. And we were researching just about the time of the 2018 pay negotiations and award, in which people were able to talk and point to the role of partnership in producing a process and a set of outcomes that were better, for example, than the settlement that was made in England and Wales. So in that sense, that equity side has been delivered in many ways by partnership. What about its effectiveness to the NHS as an organisation? Well, it's clear that the period of stability over more than 20 years in industrial relations in the NHS has been underpinned by those very positive partnership relationships. They're not always positive, but they're largely positive. It's been effective because, as I said earlier, those material benefits feed through into important elements of workforce management around recruitment and retention. That partnership underpins, and I'll give a specific example, much greater staff engagement. Crucially, and perhaps sometimes underdeveloped in discussions of partnership, it can be incredibly important in delivering innovation and change, and the NHS has to be a highly innovative organisation. It has to change a lot. It's changed enormously over those 2 decades, and partnership has allowed the facilitation and the delivery of that change in constructive ways. And all of those effectiveness outcomes are part of what drives the commitment and the delivery of continuous improvement and better patient outcomes in the NHS. Another really important part of partnership is that it delivers particular types of relationships, and those relationships in turn go on to support the other outcomes associated with partnership. So when we talked to stakeholders across all of the partners, it was clear that there was a strong and very widely held view that partnership had actually transformed relationships really significantly, a move away from constructive to from adversarial to much more constructive engagement, a move away from seeing other partners as the problem rather than partners starting to see each other as part of a collective solution. The building of much closer relationships, so they weren't distanced and discrete and distinct in time, but they were ongoing, close and cross-cutting across different types of activities. That people had moved away from posturing and positioning in terms of their own interest groups, but had much better, honest conversations and dialogues about the challenges facing both the health service and the health service workforce. And that had driven a very important shift from low to higher trust relationship that continued throughout the period of the partnership. And I want to give just a couple of very practical examples, not just of how that partnership has delivered good relationships, but how it's delivered real change that impacts on the delivery of services. There's lots of examples that you could choose from, but in this context, I'm going to focus on a couple of pieces of research that we've been involved in over the last few years. And the first is some work that we've done on, I've put the reference to the reports there if anybody's particularly interested in looking at those later on. The first is some work that, oh, I think I clicked on it accidentally there and nearly opened it for you. The first is a piece of work that we did a few years ago in a major health board in Scotland, looking at organisational and technical restructuring of hospital pharmacy services. So taking pharmacy services from being embedded in specific pharmacies in hospitals, which all operated across all pharmacy functions, encouraging a move from clinical pharmacy into wards so that they weren't in dispensaries, but they were in wards. Combining the service so that delivery and supply and dispensing of drugs was automated, including installing the largest hospital robotics installation in Europe, which serviced multiple hospitals and healthcare settings. And that was a long, tortuous, complex process of capital investment, of organisational restructuring, of workforce redeployment, really significant workforce redeployment, which delivered a complete transformation of pharmacy services within a particular health board. It would be entirely dishonest to say that that was seamless, because it was far from being seamless. It was exceptionally complex, upsetting, stressful, but it was a fascinating example of how the partnership framing overall shaped the decision to use a big capital investment in organisational restructuring in this way. But partnership and collaborative working and the kinds of values and relationships that embedded also allowed problems to be solved, major challenges to be overcome, creative solutions to be found, and the whole process ultimately to be delivered successfully with, alongside, no redundancies for staff involved, because there's no redundancy commitment in the Scottish public sector that applies to the NHS, but also a no terms and conditions detriment arising from organisational change and redeployment. So you undertake a really massive capital and organisational investment, and you do that in a way that's transformative, but in which the partnership structures were involved at every stage. Similarly, we've recently, Colin and I and our colleagues have been involved in looking at the way in which an initiative called iMatter has been used within the NHS to support staff engagement. Staff engagement is really important, and I'm sure Shirley will come on to this as a priority within the NHS in terms of employees' experience, but also in the way in which it supports motivation, commitment and empowerment, and delivering the kinds of workforces that can produce the organisational goals that the NHS needs, that can deliver good health and care outcomes for patients and for other service users. So iMatter was really a development out of the National Staff Survey in Scotland, where the NHS collected a large amount of data for its own staff and acted on some of that. But iMatter was a way of moving from that being a relatively passive form of engagement with staff to a much more active form of staff engagement. And it was a process that was designed and implemented through the partnership structures, but designed from the ground up. So it started with NHS staff and what they wanted and how they defined what they wanted and what kind of engagements were important to them and the outcomes of engagements that were important to them. And it developed that into a national initiative, which could be used across the NHS in a variety of different, and indeed across social care in a variety of different ways. And crucially, what iMatter did, and I can't go into much of the detail of it, but what iMatter did was to take the responsibility and ownership to make successful innovation and change and put that at task and group level. So to give lots of responsibility for identifying challenges, addressing how those challenges might be met, implementing solutions, take that down to the task and the group level and give ownership of that under managerial leadership to those people who could best understand and deliver what needed to be done. And iMatter has subsequently been rolled out beyond the NHS to broader health and social care partnerships in Scotland, so therefore it includes many staff now who are not part of the formal NHS partnership, but who work for local authority, social care and social work staff. So it started to bring together the knowledge of the health and social care workforce in very important ways. I won't go into much of the detail of this. It's just a nice little diagram that tells you what iMatter was about, that it's a survey, that it maps against the governance standards, that people get certain kinds of reports fed back on the basis of the number of responses that they have, that responsibility is given to the team to implement, and that the whole purpose of iMatter is not just for employees to say what they think and feel, but for employees to be able to say what they would like to be done, and in fact to do it, to take responsibility to go ahead and deliver the outcomes. And one step beyond that, to then use those outcomes to share with other people, to encourage, support and disseminate other forms of workplace innovation and change. So it works also as a kind of organisational learning tool. Really crucially important because it was bespoke and delivered by staff. It focuses on localised feedback. It encourages a very high level of response, and it's a very practical, specific approach to partnership at a task and a group level. If we draw back then from some of those examples and the broader understanding of partnership from the various research that's taken place, what would we identify as being the critical enabling factors that people could learn from? So if anybody else is interested in instituting partnership arrangements, what are the critical enabling factors that they need to think about? It was very, very clear from our research that the commitment to partnership values and to owning partnership, even when it was difficult, even when people didn't agree, even when they thought others might be behaving unreasonably, that commitment to the values and the ownership of partnership within the NHS was enormously strong, incredibly strong, and very closely connected to how people thought a good healthcare service should be delivered, whatever its demands. There was extensive knowledge and experience of key partners from inception right through, some of whom were still around at the time when we were doing our research in 1819. So a group of actors who had engaged in that journey for a very long time and stayed with that journey, sharing that knowledge and experience over the piece, as well as some new partners who had come in. Largely supportive and collaborative relationships among partners. I'm sure Shirley will tell us that they didn't all love each other all of the time, but those relationships were strong and supportive, and people understood the interests, the perspectives and the priorities of other partners. The commitment to joint decision making and the idea that you get the best decisions if you design, you deliver and implement them jointly was at the heart of everybody's discussion about partnership. And that included the notion that you needed to find consensus, that in order to implement successfully, to implement policy, to implement change, then the consensus had to be found one way or another, and that involved often a lot of blood, sweat and tears, but the consensus was arrived at. There is no doubt that investment by the Scottish Government and by health boards, real investment and symbolic investment also really heavily supported the view that partnership was a legitimate activity. It was an important thing to be engaged in, but also the investment in the capacity of partners to be able to act in partnership. Partnership's not something that necessarily comes easily to everybody. There are important skills and behaviours that have to be learned. So that capacity, the number of people, the capability of those people to be able to act in partnership was very heavily invested in across the board in Scotland. And there were some very strong material and symbolic enablers. So the commitment to no redundancy was an important part of saying this is a partnership. The partnership doesn't end when we put you out the door. No redundancy allows people to know that they can take decisions, difficult decisions, risky decisions in some regards. They can take them with the assurance that they won't lose their job, or indeed that they won't, because of the no detriment policies in organisational change, that they would not lose materially from the kind of outcomes that the partnership processes might deliver. So those are really, really important enabling factors for the success of partnership. I'm certainly not going to suggest, and if I did suggest it, I'm sure Shirley would put me right when she speaks in a wee while. I'm not going to suggest that it wasn't constrained and challenging, and that there are not ongoing concerns about how partnership operates. The nature of collaborative decision-making processes are inherently messy and difficult and challenge lots of people in their own particular views and approaches. There is inevitably, in any group of people, variations in commitment to and engagement with partnership across employers, unions and government. So the extent to which people were committed had some variation in it. Crucially, and this was what stimulated the review that we engaged in the first place, new health and social care structures within an integrated landscape that sat outside of the formal NHS partnership structures were challenging. They were different bodies, they were different groups, they held different configurations of actors. So a really significant role for local authorities in health and social care structures. They're an important partner in those structures, but not relating to the partnership process in exactly the same way. And that raises big challenges as to how, in an integrated landscape, partnership delivers for all of the people in the health and social care landscape. And there were some areas, not massively significant, where some of the communications, linkages and relationships between the partnership structures at different levels worked better than others. So the link between national policy and area partnership fora was stronger in some cases and less strong in others. I suppose one of the things which people often ask about partnership is, does it slow things down? And the answer to that, lots of people thought was yes, but it made it better. It was solid, but not fast. So things didn't necessarily happen very quickly, but when they happened, when policy was adopted, when initiatives were adopted, they were capable of being implemented much more quickly and much more effectively. So if I was to summarise what our evaluation of partnership working concluded in terms of the views of key partners, it was that partnership had delivered, there's a broad consensus that had delivered a really important process and a set of practices, so sharing information, accepting that people had legitimate voices, distributing the ability to influence, a process of collective problem solving and balanced decision making. So partnership had delivered those processes, and those processes produced three really important outcomes. The first being decisions that are collectively endorsed even if you don't like them. So decisions that people arrived at through a joint decision making process, aiming at consensus. Not everybody always got what they wanted, but the decisions were collectively endorsed and supported. That it produced a second outcome, which was benefits and costs that were fairly shared. And there was an appreciation and an explicit recognition that benefits and costs had to be shared. And a shared mindset for managing change in a variety of different guises that took. And that all of those things, that process and those outcomes, delivered the two overarching outcomes which were sought from partnership, which was staff engagement and high quality health services. All of that, of course, takes place before the pandemic. We clearly have not done any research in the NHS in the pandemic. During the pandemic, and neither should anybody else, because the NHS has been too busy doing much more important things. But it's clear from the formal statements in relation to partnership working during that time that the emphasis on partnership working has continued, and that partnership has been part of the emerging emergency planning structures that have been delivered in the NHS in Scotland over the last year, that the approach of partnership has characterised decision-making and activities, but that of course people have agreed to vary processes and procedures and to streamline them as a consequence of the pandemic. And I'm sure Shirley will be able to make some reference to some of that. What does it mean for the future? I always like the bit in a presentation when you can just speculate. I think there are some key issues around the maturity of health and social care integration and the extent to which partnership or a variation of partnership or an approach like partnership characterises developments in the social care workforce. And there are a number of developments within Scottish Government and elsewhere which are about thinking very closely about the voice of that social care workforce and how that voice becomes more formalised and becomes more effective. There will be some real challenges around the pace of change to respond to the many other adverse consequences of the pandemic other than the pandemic in terms of things like waiting lists and services. There has to be a concern, I think, on behalf of anybody concerned with the health service about what happens if we end up in a period of future austerity in which partnerships have to deal with much more constrained resources than they have in the past. And crucially, given the demands of the healthcare workforce, what will be the implications for well-being and burnout, not just for the NHS workforce as a whole, crucially important that is, but actually for the active partners, for the people who have driven and encouraged and engaged with partnership much more intensively over the last few years. All of those things raise issues about the capacity to deliver on partnership, the capabilities that people bring to it, the resources that they can draw on in order to be able to engage in partnership. But all of those have really well embedded learning and experience, positive experience on which to build, which I will hope will make that very positive for the future. And I can't think of anybody more appropriate to hand on to at this point to discuss some of these issues than Shirley Rogers. So Shirley, over to you.
Thank you very much indeed, Patricia, and thank you everybody for joining this event this afternoon. Can I particularly thank those of you who are missing the football? It's 2-0 at the moment to the Czech Republic, so perhaps it wasn't such a dreadful match to miss for us. But I wanted to actually start by giving a heartfelt thank you to everybody on this call for all that you've done in the last 16, 17 months. It's a period of time that has been inconceivable, really, for everybody who lives and works across the world, but particularly in Scotland, since I'm speaking at this event. Whether you've been contributing to the COVID response, whether you've been juggling homeschooling, whether you've been juggling the work, the pressures of your work, whether that's in the health service or beyond, in the care service, in business or the private sector, or whether you've just been rolling your arms up and being vaccinated and managing to make sure that you can look after the people around you and the people that you love. Thank you. Thank you. I start there because it's true, but I also start there because partnership working, which is as Patricia's touched on, is a relationship between Scottish Government, employers, initially the health service, but as she's described already, not exclusively the health service, in particular around health and care. We'll perhaps touch on a little bit of that. The employers generally, and our staff, is an absolute reflection, an absolute necessity, in my view, to change. And if we look back over the history of the employment relationship, it seems bizarre to me that anybody could conceive that organisations have to change without thinking about the relationship that those organisations have with the teams of people who work in them has to change. And if anybody's in any doubt about that, throughout my time as the NHS Chief People Officer, and I continue to work for NHS Scotland for what it's worth, but I've worked in NHS Scotland for 20 years now, a lot of years. And we've, throughout that time, taken soundings about why people join the NHS and what they look for. And what they look for is exactly what you would expect of a professional, highly skilled workforce. Of course, they look for pay and benefits and all that kind of stuff. Of course they do. Everybody does. But they also look for organisations that reflect their values. And those values have changed in the last 100 years. Why wouldn't the employment relationship change? They look for organisations that make a positive contribution to society. And I think health and care could always say that. But that's what young people in particular are telling us that they look for at the moment. They look to not be in the gig economy. They look for organisations where they can make a long-term investment in their future, and the employer's going to do likewise. So they look for educational opportunities, they look for promotion prospects and so on. So as we talk about partnership working, and we still talk about it in relatively new terms, it's absolutely critical and very clear to me that if we live by the do as you would be done by principle, that has to change. That has to have changed over the last few years. And the journey that Patricia has described will continue to change over the coming years as people get more into engagement, as people get more into understanding where they fit within their organisations and how they can make a contribution, but also how they're valued. Now, come on, the one bit that I would have challenged in the research from Patricia, not Patricia's research, but in the research findings, is the solid but not fast. If I think about how public services have transformed in the last 16 months, they've actually been really fast, really, really fast. And I would argue that some of the reason for that is because the nature of the relationship between organisations and the people who work in them has fundamentally changed. But it comes from the principle that says you're better at work if you're engaged. If you want to look at productivity, we're no longer in the time and motion, give somebody a big shovel end of the market. We're in the space of people who have a huge professional skill set, whatever you do, whether you're a clinician, whether you're in a care role, whether you're in an operational role, whether you're in HR or wherever you are. That professional cadre of skills that we can draw on now is enormous. But professionals expect to be treated in a particular way. They don't expect to have somebody checking up on their shoulder all the time. And actually, it doesn't work if you do. People expect to be able to be engaged with their work. People expect to be able to make a contribution to how that work is shaped. And they expect to see their values manifest. The one thing that really I tried throughout this process to make sure was that values were not a poster on the wall, was that values could be felt. That there's no good me saying that our values are about care and compassion if your daily experience of work has got no relevance to care and compassion. If you don't see it, if you don't feel it, if the organisation doesn't support you when you're in need. That sounds awfully cosy. It isn't actually. It's really, really hard because you don't always get it right. At the time I left being NHS Scotland's Chief People Officer, health and care at that time had something like 400,000 people working in that environment. Don't get it right all of the time. Some people have not understood that behaviours have changed over the last few years. Some people still operate in very traditional kinds of ways. And challenging that and being supportive in challenging that is really, really important. We don't always get it right. So it's not cosy. But my honest view was that if you are looking to have an engaged workforce, having values at the heart of that strategy, if I think about the Everyone Matters HR strategy, it started with its first priority was, and its first deliverable was, a huge piece of consultation and a huge bit of implementation around what the values should be. And that was so fundamental because without knowing that you're building your house on rock, you're always going to struggle a little bit. Coming back to that principle, the principle that people work better if they're engaged. There are some features around that about health and social care. The people who work in health and social care, generally speaking, work in that environment for a long time. Particularly in the health service, it was routinely my privilege to be able to hand out certificates and gongs for 30 years and 40 years service. I've worked in the NHS since the mid-90s. I'm still a baby in comparison to many of the people who've worked in that organisation for an awfully long time. And that is just amazing and fantastic and brilliant. But it also means that people have got memories and they're not stupid. People have got memories and they're not stupid. So their experience of work is cast through a reflection of 20 or 30 years in that space. You can't simply arrive and be today's new thing and then go away and tomorrow be the next new thing. People have got experience, they've got memories. They know how organisations have treated them. So the first criteria for partnership working really was that you didn't set out to do something unless you were prepared to really do it. It's not good enough to just do it in easy times. You have to do it in hard times too. It's not just to do it when everybody agrees. It's actually even more important that you keep to those principles of partnership working when people don't agree. And that, I think, was really, really important. Patricia, in her presentation, pulled out a few things that helped that journey. Security of employment. It was really, really important. If you're asking people to change, how much risk are you prepared to take? How much risk do you think your employees are prepared to take? How can you secure, in the knowledge that we are always making sure that we've got as many vacancies filled as possible, how much risk are you really taking to be able to say to people, our population is going to need care next year as well? So instead of dangling these risky things, excuse me, let's just take the risk away. We're not going to make people redundant. We're going to need as many doctors next year as we needed this year, if not more. We're going to need as many care workers next year as we did this year, if not more. So there's no risk in being able to say to people, you work with us in this space, and we will make sure you continue to be employed. And we'll continue to make sure that you're developed. There's the old adage from the old joke about what happens if you invest in your people and they leave, to which the response is always, what happens if you don't invest in them and they stay? So there was no risk corporately in us being able to say no compulsory redundancies, because we didn't want people to leave anyway. We needed more people. There was no risk in us saying we need you to be flexible. So the holy trinity, if you like, about being a leader for managing people is that you want commitment, you want productivity, and you want flexibility. And things like no detriment helped us to achieve productivity, commitment, and flexibility. As people were prepared to come with us and change things, partly because they'd been well engaged, and partly because they knew that they could do so and still be able to pay the mortgage. So there were some factors for success in there that were really, really important. In Patricia's presentation, she set out a slide that had National Partnership Forum, area partnership forums, and so on. That was a reflection from us that actually things needed to work in your place too. So there was a sense of place in that space that said, actually, some of the issues are universal. But some of the issues are different if you're in Orkney than they are if you're in Glasgow. Some of the issues are different if you're in an on-call, 24/7 operation than if you're in a different kind of working arrangement. And let's put some agency into the people who are doing this stuff so that they can, within a framework of principles, actually do the things that make sense for them to do at local level. So that area partnership thing was really, really important. The Scottish Government had a role in that space. And it wasn't a role, I suspect, that was visible to everybody working in those health boards in particular, and health and social care partnerships later. But we actually held the boards to account for that. So when we came out to do annual reviews, we met with the Partnership Forum. When staff survey results were received into SG, we held boards to account for developing an action plan. And we held them to account for developing that action plan. So if we went back the next year and it was still the same, then we would continue to work hard to make sure that those developments were reached. That became so much better and richer with iMatter. The thing about iMatter was partly about giving agency at local level so that people could say, this is what's happening in my team, this is how I'm feeling, this is... But it was also about saying, and some of the responsibility for fixing some of those things rests locally too. but it was critical in bringing teams together. So the fundamental difference between staff survey, apart from the passive and much more active stuff that Patricia's already spoken about, fundamental difference was it allowed people to see what their team thought. You weren't alone. You could develop things locally for yourself. Sometimes partnership working required us to take action, and some of that action wasn't always easy stuff. There were a number of issues that needed to be addressed around culture, around bullying, around issues of concern around things like race, and whether or not people felt equal in the workplace. And it's particularly auspicious that I'm speaking to you today when NHS Scotland has announced its latest approach around equity and the sort of equalities model that needs to be more fully understood. But what we found was actually, all right, those things were sometimes very difficult individually and organisationally. But you needed to put your money where your mouth was a little bit. And if you see that the organisation is not doing things in the partnership way that you're expecting it to, taking action is really important. Taking action was really important in a number of different ways. One of the other things that was difficult sometimes, but is fundamental, is if you get it wrong, say so. And sometimes we did. And sometimes you just have to say, we're sorry, that didn't work out quite the way that we thought it was going to. Sometimes the pace that was required didn't allow for the fullest engagement. And when that happens, hopefully you've built trust, which is what this is fundamentally about. That trust comes from actually doing what you say you're going to do. It comes from not having a poster on the wall. It comes from remembering that people work with us for a long time. And it's important, therefore, even more than it would normally be, to be honourable in that space. But that whole point about that holy grail of productivity, commitment, and flexibility was absolutely at the core of why we did what we did. And an understanding, as I say, that it would have been ridiculous to try and move into this century's employment with last century's employment relationships. It just wouldn't work. It just wouldn't work. We wouldn't attract the best in the world, and we sure as hell wouldn't keep them. So we needed to put this effort into partnership working, even though sometimes it was really difficult. I think one of the advantages that we had, and I will talk in the health service at the moment, because I wouldn't be so presumptuous as to say that I understand social care as deeply, having worked in the health service for most of my career. We had a common purpose. Nobody I've ever worked with in health or care, actually, in this space, has ever said, we want to go to work today to make it worse for folk. Ever. That common purpose of being the best service that we could be, providing as best we could, looking at individuals, treating those patients with dignity, respect. And we've all seen the research that says if you treat your colleagues with dignity and respect, you're more likely to treat your patients with dignity and respect. If you know that you are going to be treated with care, compassion, and respect, surprise, surprise, you are more likely to treat other people with care, compassion, and respect. So we always had a bit of a common purpose. Patricia mentioned something earlier on, which I just want to expand on a little bit because it's so important, really. That for health and social care, there was a three-legged stool about clinical, financial, and staff. Or as I would have said, staff, clinical, and financial. That absolute triumvirate that says, we can't do anything that we do without people. We can't do it. We wouldn't last half an hour without people. And not only that, but all that we do is for people. So that absolute embedding of a sense that if you want people to have a good experience of your service, they have to have a good experience working in it, was completely fundamental. That doesn't always happen. You know, I'm not going to sit here and say 400,000 people went to work every day and all thought it was perfect. But we learned, and we learned a bit more, and then we learned a bit more. And we did what we thought was best until we knew better, and then we did that. And then last for me, I started by saying thank you about COVID. For the last year, I've been helping to lead helping to lead Brexit, unfortunately, helping to lead COVID, and doing the work that we need to do about organisational readiness, resilience. As you can imagine, there's been quite a lot of that in the last year. It was a source of immense pride, but no surprise to me, that everybody who was called upon to do their bit, did their bit. It wasn't a surprise to me because I know an awful lot of people who work in health and social care, and I know them and I know their principles and values. But it also wasn't a surprise to me because 20 years now we've been at this game of engagement, of partnership working. So people know their organisations, they know where they fit, they know the arrangements that would take place on normal consultations and all that kind of stuff. And people demonstrated huge flexibility, huge flexibility. I'm very privileged. I've had 2 vaccinations. The people who vaccinated me were not people who were doing vaccinations this time last year of anything, never mind COVID. The people who met you at the door were people who were not doing that role last time. The people who sent those letters were not doing that this time last time. So that huge flexibility, and we're going into a post-COVID, hopefully going into a post-COVID period over the next wee while. And we'll change again. And we'll have seen some of the things that we've learned that have worked, that have been powerful, that have allowed patients to get a different kind of service, that have allowed staff to be able to do things new and with innovation and with a difference. And we need to keep that going, because when we come out of COVID, there'll be something else. Hopefully, please God, nothing as significant as COVID. But those changes in innovation, changes in the way that people access services, changes in the way that people go to work, the relationship with work is just absolutely fundamental. And I have absolutely no doubt that we'll rise to those challenges, at least in part because people feel part of an endeavour. I said earlier on, health and social care at the time I demitted office employs about 400,000 people, private sector, public sector, and the NHS. That's a huge proportion of the Scottish population. The impact that we can have on how Scotland feels about its employment relationship is enormous. Is enormous. And when we do good for each other, we're actually doing good for a huge proportion of the Scottish working population. So I'll end where I started, if I may, just by saying a huge thank you. If you've been on the front line, thank you. If you've been on any other response, thank you. If you've been working away, sending out letters, thank you. If you've been juggling school and home, thank you. And for anybody who's rolled up their sleeves and been vaccinated, I couldn't be more proud of you. Thank you.
Okay, and let me again thank you, Shirley, for everything you've done and the colleagues have done. And thanks to both Tricia and Shirley for a hugely informative talk. We only have a few minutes for a couple of questions, which I don't think is a problem because, like I say, I think it's been hugely informative. Maybe the first thing to you both is the future elephant in the room, and I realise, Shirley, you've moved on from the quandaries of health and social care integration, the emergence of a national care service. from both of your prior experience, how easy a fit is the NHS model of partnership to a fully embedded approach to health and social care integration and a national care service, and what might be the challenges around that? Maybe if you want to start, Tricia, or Shirley, you start, and then Tricia can come in.
Shall I start?
Yes, please.
Well, to some extent, we've already demonstrated that partnership working is an approach, and it's an approach that could apply, I would argue, to most employers. It's easier to fit into those organisations that already have some of those existing arrangements. And it's easier to fit, and I think we'd be foolish not to acknowledge that it's easier to fit into those organisations that have a public duty, I suppose. It's harder to give longevity if you're in a privately owned situation where something unforeseen may happen. I'm reasonably confident that it could be delivered in that space, and that's not just sort of wide-eyed Pollyanna stuff. It's because if we look at things like iMatter, for example, they were very quickly adopted way beyond the boundaries of the NHS. That was delivered into health and social care partnerships very, very quickly. And actually, I think to good effect. I also have to say that having had local authority involvement in that space, the product got better too. So it wasn't about a thing, it was a thing. And that was really, really important. So my view is, could it be done? Yes, it could, but I suspect it will change a bit as it goes. It will be influenced by the different kinds of organisations for which it applies. But, you know, values are a funny thing, aren't they? You can change your shirt, but you don't change your values very often. And when we did that values work for the NHS, we landed on 7 words eventually, or we didn't. 10,000 initially of NHS staff landed on those 7 words. Interestingly, when I Googled all of the values of every public sector organisation in Scotland that published its values, those 7 words were pretty common. I think we only found 13, and some of them were variations of the 7 that we printed. So they might talk about care and others might talk about caring, but they were broadly similar. So on the principle that something is based in values, and that I've never yet heard an organisation say it wants to be uncaring, not compassionate, not fair. My guess is with determination and a fair wind, these are values and principles that could be adopted fairly broadly.
Thanks, Shirley.
I agree very much with that, and the point I was going to make is almost exactly the same. If you think about partnership as being a set of structures and mechanics, then the issue about its transferability and its reach might look more negative. But if you think about it as a set of values and principles that are deployed and operated in context, and the way in which they're operated in context in different parts of the health service, then there is no real barrier to their transfer. And I think the second point I would make is that the principles and values of partnership are very close to how we've defined fair work in Scotland. So the kinds of things that Shirley has talked so eloquently about are very much embedded in what we think is the approach to fair work that can travel beyond health and social care, can travel beyond the public sector, can travel in the very organisations that recognise the kinds of things that Shirley talked about the importance of having the right kind of workforce doing the right kind of thing and treating them appropriately. So undoubtedly, the form of it might look different. There might need to be tweaks and changes. There are some real challenging issues, I think, about some of the underpinning supports not necessarily being there in some parts of the social care sector. So how do you use an effective voice when there's not a collective voice? That's a challenge, but it's a challenge that will need to be overcome. It will need to be addressed. But in terms of the broader approach, which is these are services which, if you don't get the right people doing the right thing, you don't deliver the right services. Then bringing all of those constituents together to be able to exercise their voice, to work in the right way, to behave in the right way, to do the right thing when that's required. There's no barrier to that, and hopefully that's something we'll see a lot of movement on over the coming months and years, in terms of the extension of partnership to the broader social care workforce. And I think iMatter's had a very important role to play in that, because it's been a useful approach which has been able to be adopted in context, and context matters. But context doesn't trump principles and values. The context is what you adapt to. The principles and values are what you adhere to and you stick to.
That's great, thank you. We're just about to run over, but I'm going to try and sneak in one last question, if colleagues will bear with us for 2 minutes more, and then we'll close. Because I think it was a matter of a little bit of debate in your two presentations around the extent to which partnership can sometimes elongate things, make things a little bit slower, although there's reasons for that, versus dynamism and innovation. Shirley, you were suggesting, look at the last year, where we have been dynamic, it's demonstrated it can work. However, I think in your research, Tricia, it's something that you've raised, that, you know, there is a slowness there. I think if we speak to lots of our colleagues from Nordic countries who are very used to social partnership working, one of the things they would say is it's a fantastic foundation to deliver brilliant services and a great employment relationship. But I'm thinking about a Danish colleague of mine who said that sometimes the emphasis on consensus means that the can does get kicked down the road. And if you're trying to innovate public services, that can be a challenge. You seem very confident, Shirley, that the two fit well in terms of innovation and these collaborative structures. So can you, other than what's happened in the last year, or drawing more on what's happened in the last year, can you make one last argument in favour of that? And Tricia, maybe you can either critique or agree with what Shirley says in terms of that.
So I think if I tell people to do something, they're likely to do it whilst I'm watching. And that's quite quick, as long as I can watch a lot. But I think if people can understand, share and help design something, they might even do it when I'm not watching. And for most of what we do in health and social care, the kind of supervision that might have been suitable on a factory line just isn't going to work for us. So do I think it's quicker now? I don't know whether or not I would say it's I can remember, I mean, I'm long enough in the tooth to have worked in the NHS in Scotland for longer than partnership working existed. And I can remember being a director when we were starting to pull together partnership working. And it was, you know, it could take a while. We had all sorts of discussions about who's in the room, who's not in the room, who's on the agendas, who's not. But we're beyond that now. And I think the other thing, and I don't know quite how to say this diplomatically to your colleague from Scandinavia, but in my experience, I almost never know somebody's job better than they do. So if I'm going to come up with a cunning plan to change it, it probably makes a bit of sense to talk to somebody who actually knows it and does it. I think most of us could label the jar, you know, what does a physiotherapist do? You can do that. The daily operation of being one, a bit less so, to be frank. So speed to do something, if you do it right once, is not quite the same as speed to do something, tweak it a bit, do it again, recognize that it was wrong, rip it up, do it again. So it depends, you know, it depends where you think the finishing line is. So if it's just a project, maybe you're right. If it's actually doing something that changes stuff, if it's actually doing something that improves stuff, I'll take my bet.
That's a great answer. Tricia,
Three very quick points on that. One is the solid not fast was a quote from one of our research respondents, wasn't our evaluation. Just want to put that out there. My second point is, I suppose that's steeped in what we hear a lot about collective decision-making processes, that by their nature they are complex and they are slower. But the trade-off is between, as Shirley has just outlined, a better outcome, something that you can implement, something that you can implement more quickly, something that you can implement that will last. So I think, you know, there is often a discussed trade-off between the pace and quality of a decision. I think when we're talking about the nation's health, we probably really want to focus on the quality of that decision. My third point is, if the last year has told us anything, if it has told us anything other than all of the efforts and sacrifices that people have engaged in, it has told us that when you've invested in people, when they have good jobs, when they've got scope to respond, they can do a lot of things immensely quickly. They can find the right things, they can identify the right solutions, they can put those solutions into practice at a rate of knots. The building blocks of that weren't yesterday or last week or last year. The building blocks of that are in the careers and jobs and relationships that have been built at work over a long time. And we've seen that in our research across a whole range of organisations, not just in the public sector. So many employers have witnessed the benefits of the investments precisely of the type that Shirley has talked about. They have witnessed the benefits of those investments over a long period when the sky fell in and the world collapsed and we all had to do things differently. And I think that that's almost the other side of that investment. You invest in it because it's the right thing to do. It comes back and pays you rather a lot of rewards.
Patricia, Shirley, thanks so much for a hugely informative and stimulating hour. Really enjoyed it. And for those of you who joined us, thanks very much for joining us. And for those of you who couldn't, the recording will be available on the propelhub.org website. As I mentioned, this event is part of the Propel Hub and HPMA Health and Care in Spotlight series. The next of these events happens on Friday with my colleagues Richard Sondry and Roger Klein talking about inclusive leadership in the NHS. Join them if you can. Again, you'll find the details on our website, propelhub.org. Please complete any evaluation material that comes your way. It helps us to do these things better. And with that, again, thank you, colleagues, and everyone who has joined us. Thanks, Tricia, for your terrific insights. Thanks, Shirley, for your fantastic insights and leadership in this space. And hope everyone has a very pleasant evening. Thanks for joining us.